friends and our guests. I'm sorry. I'm just going to show my face that I'm here, and I hope members will appreciate that. I'm going to switch off my camera. In welcoming everybody in this meeting, I don't know whether we must still say Happy New Year because now it's February. So when it's February, the the year is we're almost done. But I want to welcome members of the steering committee that are present and our guests from the Department of Health. As the committee, which then as the steering committee, we are taking it's our responsibility within between the broader steering, the multi-party women's caucus, and the work that the caucus is to do. That responsibility lies uh, uh, squarely on our shoulders. But I think it's important that every time we meet with either stakeholders or department, we 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 express the fact that we are not a portfolio committee. We are more of an activism committee, which is a link between our citizenry and parliament. Parliament with citizenry, through stakeholders and whoever that has got an issue that would like parliament to address on matters that are affecting not only women, children, males, workers, and whatever. So I just want to make that to be clear because our responsibility is to have an understanding what then the Department of Health is doing in terms of a particular matter that would like to be empowered on, which today is it's a briefing on the non-communicable communicable diseases. So we are to be empowered for us to be able to respond when we meet with stakeholders or whoever is raising an issue through us, but also to empower a portfolio committee or a department for that matter on a matter that we may have picked up either on our constituents areas where we are deployed as political parties or as individuals, as public representatives, or as a structure. So I'm raising this so that I'm making an emphasis on this matter so that departments be aware that this is not just a by the way committee, a, the multi-party women structure, which then has got a steering committee that is to deal with its business. It's not something that is by the way. It's a very important structure. So I thought when I opened this meeting, it's what I am then to make an emphasis on. And well, we have identified this because we want to advocate on issues, among others, of the improvement of health uh, of our people, in particular women. And then we increase by so doing, will then be increasing the women's health. and the engagement on non-communicable diseases affecting women from part of the key activists under the strategic focus areas. This engagement session is particularly important as it aligns with the measures outlined in our midterm development plan 2024-2029 to improve the health care of families. The MTDP mandates the state to address and reduce the burden of non-communicable diseases. As a structure, we are concerned with the empowerment of women, and the Multi-Party Women's Caucus believes it is essential to engage on matters so that we empower ourselves and women in our constituencies about the non-communicable diseases. By empowering women, we contribute to early detection, prevention, and awareness strategies that help to ensure women are not further burdened by disease, especially those already are vulnerable by social inequalities and financial hardship. This also means that the Multi-Party Women's Caucus is contributing to the achievement of the country's development goals as outlined in the MTDP. The successful achievement of these goals is everybody's business, not only of the state or the committees that are conducting oversight. Every structure and every individual is expected to play a role. Let us therefore engage. We are therefore engaging with the Department of Health as a partner and as a stakeholder in enhancing our knowledge so that we can impact back to our communities. So I thought it's important that I raise those in when we are dealing with this first meeting of ours. And with those, I'm welcoming members of the steering committee, as I've said, our guest and the staff. Having said that, I will request, therefore, Ms. Moni to take us through our, if are there any apologies. Over to you. And I hope I'm audible.
Yes, you are, Chair.
Thank you very much. Over to you, Ms. Moni.
Thank you, Chairperson. Good morning, Chairperson, honorable members, colleagues. Chairperson, we received 5 apologies. One from Honorable Magci, Honorable Kanyile, Honorable Minister, Honorable Deputy Minister, and the DG. Those are the apologies for today, Chairperson. Thank you.
No, thank you. Thank you very much. Can we get the acceptance? Who is accepting the apologies? I've got a new gadget. If somebody wants to speak, we'll just indicate by the voice. I won't have a problem for now until I empower myself. Okay, there. Well, I think from my side, I'm a bit concerned about the apology, the non-attendance by the minister, his deputy, and the DG. And I'm of the understanding that this meeting is not a meeting that the department was made aware of day before yesterday. I make an example, and I think the committee secretary will remind us when. And I want whoever is from the department to convey this message. I will, for now, I will take that. I don't think the department is not taking this structure serious. But in moving forward, I think when we are calling you again to make a presentation on a particular matter, we would appreciate you to have the ministry in terms of the political head of the department and the DG as the head of the administration. It's not that we are undermining people that have been delegated powers on particular areas, but it's just that we want to stress, I'm stressing this on behalf of the committee, is that please convey to the minister and the DG that next time we wouldn't take this very kind. Having said that, we are going to go through introductions. I will start by my, sorry?
Sorry, Chairperson, there's a hand from Honorable Tembekwaya.
Over to you, Honorable Tembekwaya.
Greetings, Chairperson, and everyone who's here on this platform. I just want to find out what are the reasons for the apology of the Minister, DG, and Deputy? If they can be stated to say they are absent because of 1, 2, 3.
Okay. Ms. Moy, are those reflected in their apologies?
Yes, Chairperson, I'm quickly opening the email from Upracho.
Chairperson, if I
Who's
could speak to
Brajo?
those.
Who is Brajo?
Just hold on, what's happening?
Chair, this is Jeanette Hunter from the department. I thought it's better if I speak to the apologies.
No, let's allow the committee, because it is the committee secretary that has received the apologies, and if then there are matters that you would like to either to explain to us, that will be in order. If you can just allow the committee secretary to just read those apologies.
Thanks, Chair.
Excuse me, Chairperson, through you. The secretary just said, let me see the apology from Brajo. Who's Brajo here? on this platform? With Brajo's here.
Honorable
platform.
Honorable Temekwayo, Brajo is the PLO from the minister. We usually call each other Brajo, but his name is Mr. Johan Kadla.
Rather use that way to say from this person and name that, but don't use the Brajo on this platform. Sorry, don't do that.
Okay, noted, Honorable. Chairperson, I received an email from Mr. Kadla regarding the apology of the minister, to say that the minister has already committed to attending is presiding over the stakeholders' engagement on cervical cancer strategy, same time as the steering committee meeting, which is today at 10 o'clock. And then the deputy minister also had already committed to attending the same event, which is the World Cancer Day activities on the same day. Those are the reasons for the apologies, Chairperson, that I received. Thank you.
Thank you. I would appreciate if you can speak through the chair next time. I understand that what Ms. Moy did was unparliamentary and out of order, and let's apologize for that. The DG. Any reason from the DG? It's none.
The
Okay,
teacher
Ms.
chairperson is accompanying the minister.
Okay.
Okay.
So those are the reasons, honorable members, that. But can I just check, Ms. Moy, just to confirm, when was the notice sent to the department that we are sitting today and we are inviting them?
Okay, Chair. Thank you, Chairperson. Our first letter that we sent to the department was last year in October, which the department indicated that they are not available. The next one was sent on the 17th of January this year, Chair. Thank you, Chairperson.
I think it will be important. Thank you, Ms. Moy. I think it will be important. We just hear what is it that you wanted to raise, Ms. Hunter, before I comment on these apologies.
Thank you, Chair. Let me also just show my face for a short while. Then I'll switch off to say good morning to everyone and that I'm here. Chairperson, yes, Minister is presiding over. It's coincidental that the Minister and the Deputy Minister today are busy with the same matter that this committee, the multi-party Women's Caucus, has called us for here, and it's women's health. So Minister is presiding over the first ever consultation of not just health professionals, but also civil society to have a national strategy on cervical cancer, because breast cancer is the #1 cancer amongst women, but cervical cancer is definitely on the increase, and it also seems to be very fatal amongst women. And there's problems in the country with waiting times for diagnosis and after diagnosis with treatment. So the minister is addressing this with all 9 provinces, with academia, but also civil society. And then the deputy minister is at a different function, chairperson. The deputy minister is at the World Cancer Day that has a focus on breast cancer screening. And unfortunately, both these were agreed on this. The meeting that the minister is presiding over is a huge national meeting. The deputy minister is using the resources of Pink Drive. While Pink Drive has a function, we are piggybacking so that the deputy minister lends his face to the message that women must please come to the clinics for screening for breast cancer. And as far as I know, Chair, the DG had to go to Nelson Mandela Academic Hospital. Let me also just open so I have it right here. In the Eastern Cape, because of an urgency that needs attention there. And so I also apologize for the absence of the principals, and we will appreciate it if the chair takes our presentation. Thank you, Chair.
No, thank you very much. Maybe from our side, and also the side of the department, in us stepping off this issue of apologies, communication is very important, because if the department could have communicated with us earlier, we would, as the steering committee, maybe have a brief meeting, see if we can't then be part of the stakeholders, part of the people that are going to be in that meeting. Remember that and I want to stress that we are an advocacy structure between Parliament and also our citizenry. So it's just unfortunate that nobody came back to us and the meeting, the department, the ministry was told on time. We hope that this is not going to happen again. When I am are back in Parliament, which will be in April. Unfortunately, I am, because of my bereavement, I'm not able to attend some of the things until mid-March. Then I will be physically in April in Cape Town. I think at a particular time I will then have to have a meeting with the ministry. Communication is very important, because now we are dealing with something, we are missing also something. So in accepting these apologies, can it then be stressed, Ms. Hunter, that we have been very concerned about the miscommunication. I hope members will then take that. I don't know whether it's a legacy hand, Honorable Tembekwayo.
No, Chairperson, it's not a legacy hand.
Okay.
I just want to find out if the minister, the DG, and the deputy are not here, then who is here to give us the satisfactory responses to our questions? And secondly, I just would like to know, like you say, whether they don't take us seriously or not. Do we have to continue with this? Do we have to continue with the committee today, accepting their information that they are going to share with us? Seeing that they are not here, the executive is not here. Just I'd like to ask about that.
Okay, if I can respond on that, I did when I was informed by the secretariat, I called the PLO. Remember that he is the link between ourselves as Parliament and the department and the ministry. The PLO said Ms. Hunter is the DTG in this area that we are dealing with, and she is the one that has been delegated to come and make a presentation. But I just want to remind ourselves that we will raise those areas of clarity, and then if we see it fit for the minister to come back and with the presentation, that will be fine, because they are not accounting to us. I think that's what we must, that distinction is very important. They are not here to account, but they are here to take us through on what they are doing. And if we have got some problems or some areas of clarity, we will ask them, they will go back and come, because where they account exactly, they are accounting to department. Therefore, I think it's important that we allow them. That will be my recommendation to the members. We allow them to take us through, and then as the steering committee, when we have our own meeting, decide how then do we move forward in ensuring that political heads do attend. It's just unfortunate because others, they do come. It's just unfortunate that there have been this clash, and it's just unfortunate that there have not been a communication with the ministry. So my humble recommendation would be that let's allow them, when we do introduction, we'll hear who is here, and then take it from there and address my recommendation. Let's first get the introduction and hear who is here. And in that introduction of the department, I will appreciate that they tell us their designation, what is it that they are then doing in the Department of Health. I will then start with the introduction, and then so that we allow the department also to introduce themselves. I'm Linda Ratunjwa. I'm the chair of the Multi-Party Women's Caucus and the chair of the steering committee. I'll hand over to, and then I'm in terms of the staff, it's Miss Moy, who's the committee secretary, Miss it's Miss Moy. Oh no, it's
Mbambela,
Moy.
Chair.
Come again.
Miss Mbambela.
It's Moy, it's Ms. Mapela, who's the content advisor. We don't have a researcher as yet, and we have got a new kid in the block, which is Miss Isaac, Nasle Isaacs, who is the executive secretary to the office of the chairperson. We welcome him with her because he has just joined us. He has been delegated to the office of the chair. I'll hand over to members to introduce themselves, and then it will then be the department.
Sorry, Chair, and Miss Choma, the committee assistant.
Oh, sorry for that. Sorry, I didn't see. Sorry, Ms. Choma. Okay. Can we get, can members introduce themselves?
Morning, Chair. Am I audible?
Morning. Yes, you are.
Oh, okay. I am Miss Olga Siate. I am a member of the committee. I serve in the National Assembly. The party deployed me is the African National Congress. And Chair, I just need to be noted that I am in India currently with another committee doing the study tour, and there would be struggles here and there because we are traveling and we are moving from one place to another. So my network will not be that stable. Don't be surprised when I'm in and out. Otherwise, thank you very much for this opportunity.
Okay. Yes. Thank
Good
you.
morning, Chair. Good morning, everyone in the platform. I'm Usisiwe Ndlangi Sanodada, representing the ANC in the NCOP, member of the Multi-Party Women's Caucus. Thank you.
Dr. Susan Tembekwayo, member of this committee. I don't know whether we have to talk about the designations of political parties here because we are a committee, but all the same, I'm representing EFF, but we are representing multi-party steering committee here. Thank you.
Thank you, honorable members. Department, Ms. Hunter, whom are you with?
Thank you, Chair. Ms. Dundra. Can I ask my colleagues, starting Ms. Riboni and C, please put your camera on briefly, introduce yourself, followed by Ms. Mongale.
Good morning, everyone. My name is Riboni Ntsiye, and I'm the Chief Director for Health Promotion, Nutrition, and Oral Health at the National Department of Health. Thank you.
Good morning, honorable members. My name is Caroline Mongale. I'm the Chief Director responsible for non-communicable diseases, mental health, organ transplant, and renal dialysis. Thank you.
Dr. Ndlovu, followed by Mr. Setlari.
Morning, honorable members. Good morning to DDG. I'm Busisiwe Ndlovu. I'm the director responsible for non-communicable diseases at the National Department of Health.
Good morning, honorable members and the DG and the colleagues. My name is Itumerian Setlari. I am the Deputy Director responsible for chronic diseases at National Department of Health. Thank you.
Thank you, Ms. Mkiza, and then followed by Ms. Baloy.
Good morning to the committee. My name is Mrs. Mkiza Nogwetemba. I'm in the office of the DG as a parliamentary liaison officer. Thank you.
Ms. Baloy? Anyway, I think she's probably struggling, Chair. I did not give my designation. I'm the Deputy Director General for Primary Healthcare at the National Department of Health. And one of the areas that I'm responsible for is non-communicable diseases. Thank you, colleagues. Let's switch off our cameras. Thank you, Chair.
Good morning, DDG. Good morning to the chairperson and the honorable members. My name is Lungi Swabaloyi. I'm responsible for cabinet and parliamentary liaison work in the office of the Deputy Minister. Thank you.
Okay, thank you very much. Thank you very much. We will, so that we don't waste time, we will then, we will hand over to you, Ms. Santa, to take us through the presentation. Or what I forgot, Ms. Moy and the honorable members and Ms. Santa, the PLO did call, said he will join the meeting late because he is traveling. He will be, I think he will join the meeting after 10, anytime from 10:30, because he will be still on the flight at that time. I will then hand over to you.
Yes, Chair, thank you very much. The PLO was with the Portfolio Committee, I think, in Limpopo for the last few days, and then, therefore, as you say, he has been traveling. Thank you, Chair. Chair, so it is our honor to present to the Multi-Party Women's Caucus on non-communicable diseases affecting women in South Africa. We will deal with mortality due to non-communicable diseases in general. We will provide a global and a local non-communicable diseases landscape. We will briefly touch on the leading causes of mortality in South Africa, the epidemiology of priority non-communicable diseases in South Africa and how women are affected by it, the impact of modifiable risk factors, and then also we will give the summary of the health sector's response. So if we look at mortality by gender in South Africa, Chair, the blue line is for males and the green line of the graph is for females. It's a very interesting trend. It starts in 2001 and we end in 2022 because we use the data of Statistics South Africa, and they've given us a report in 2025 with data that was including years up to 2022. Chair, if we look at how mortality for women was coming down from the year 2005, it was gradually coming down as mortality for males were going up. But then you can see the interesting thing that happened in 2020 and 2021, and it came back again. That sharp increase in the mortality of women was due to COVID-19. And we actually see that men were doing better over that time. And we have observed as the health sector that there was a strong correlation between mortality due to COVID and obesity. And as we will show to you in later slides, obesity greatly affects women much more in South Africa than it affects men. And we therefore have a strong drive towards obesity prevention in both genders, but especially amongst women. Chair, if we look at the global and the local non-communicable diseases landscape, the data tells us that non-communicable diseases account for 74% of all global deaths, and that's according to a report by the World Health Organization in 2024. Over 41 million deaths annually, and of those, 17 million can be said to be premature. That if people were not suffering from NCDs, they may have lived longer. 77% of NCD deaths occur in low and middle income country, and as we know, South Africa is a middle to low income country. And the leading causes of these deaths amongst NCDs at that time was cardiovascular diseases, cancers, respiratory diseases, and also diabetes. This is a global trend, Chair. I want to draw the committee's attention to the leading causes globally, and for the committee to note the difference when we come to South Africa and we look at the leading causes amongst leading causes for deaths in South Africa, how different it is. So in the world, it's cardiovascular, followed by cancers, and then followed by respiratory diseases, and diabetes is the fifth highest cause. And you will see how different it is for South Africa. But on this slide, we just say that NCDs are responsible for over 51% of deaths in South Africa because of our treatment, our successful treatment campaign for HIV and TB. We are losing more people in South Africa now due to NCDs than what we do due to communicable diseases. Chairperson, on this graph, the light blue line is diabetes. We've got one dot there in 2020, that was COVID. It was only in 2020 that we lost more people to COVID than anything else. Ever since then, 21, 22, as we'll see with the previous slides, diabetes has overtaken everything else. We are losing more people due to diabetes than any other condition in South Africa. Chair will see that the next line, the bright orange one, that starts in 2018 above 27,500, is TB. And thankfully, we can see how the deaths due to TB has come down. We also see by the green line that it's another NCD, namely cerebrovascular diseases, that is on the uptick from 2019. We also see with a pink purple line starting at 22,500 in 2018, how the deaths due to HIV has come down. And then hypertensive disease, the yellow line, is on the uptick. And then, of course, influenzas and pneumonias went up. And then there's ischemic heart disease that went up from 2018 to 2019, but stabilized towards 2020. Chair, this slide allows us to look at the leading mortality by gender. It allows us to look at the differences between men and women. So if we look at the first one, in the first column on the left, it's diabetes mellitus, which we in the country call diabetes for short. If we look at how much more women are dying than men due to diabetes, I'm just going to draw your attention to those that we've boxed in orange, green, and then again orange. If we look at TB, men have more TB, they die more of TB than of women. And that is because we've got an excessively higher rate of smoking amongst men than amongst women. About 9% of South African women smoke, and I think it's up to 36% of men in South Africa that smoke. Cerebrovascular disease, unfortunately, the number 3 killer, is killing much more women than men. Hypertensive disease, almost double the amount of women than men. And then I'm going to go down to chronic respiratory disease. It's number 9. And we see that thankfully it does not feature with women. And again, it's because we've got much less women smoking in South Africa than men, and we need to keep it that way. And I think as the members in this caucus will know, we are currently as government trying to get our new laws passed on tobacco control, tobacco and nicotine products control. And it would really be important for us to get that legislation through so that we can keep women from smoking and that we can get men to smoke less because of the burden that smoking causes on health in South Africa. Then the next one, we put it in there, even it's under number 10, Chair. It's malignant neoplasms of female genital organs. In other words, it's cancers. It doesn't feature in men, but it is number 10 for women. So women are then more affected by these kinds of cancers than men. Chair, as I said earlier, cancer is becoming a big problem in South Africa. We were in a meeting with the minister yesterday, and he was saying if we don't really act decisively on cancer, it's going to become our big problem the way HIV was a problem to us. On the left, these rows on the left indicates the main cancers in men, and the rows on the right in pink indicate the main cancers in women. And so for men, we see from number 1 to number 10, it's prostate, it's basal cell carcinoma of the skin, it's squamous cell carcinoma of the skin, it's colorectal cancer, it's lung cancer, it's melanoma, which is also all forms of skin cancer, and then non-Hodgkin's lymphoma, it's esophageal cancer, which is very much related to smoking. It is bladder cancer and stomach. If we look at the women, breast is number 1, followed by cervical, then the basal cell type of skin cancer, then the squamous cell type of skin cancer, colorectal cancer, uterine cancer, all forms of skin cancer, cancer of the vulva, non-Hodgkin's lymphoma, and then lastly is lung cancer. We can see how high lung cancer is for men. It's number 5 there, the number 5 most killer amongst men. And for women, it comes down to number 10. Further about cancer in women in South Africa, cervical cancer incidence and mortality rates were the highest amongst Black African women. And research shows that this is due to late diagnosis, and this is why we really need to get civil society together. And I do agree with you, Chair. I will definitely take your message back to the DG, the Deputy Minister, and the Minister, that we need to continue to communicate with this caucus, with the steering committee of the caucus, because I think your presence in this dialogue that they are having today would have been much helpful. And it's also because of the high burden of HIV in Black African women. There's a strong correlation between HIV and cervical cancer. As this next line says, women with HIV are much more likely to develop cervical cancer than women without HIV. Nearly all cases of cervical cancer are due to the human papilloma virus infection, and this is why we've got this aggressive program in the schools to cover girls with the HPV vaccine. The sustained rollout of the HPV vaccine is therefore important to protect adolescent females from infection with the HPV virus. Cervical cancer can also be prevented by regular pap smears to detect early changes on the cervix that might become cervical cancer if they are not treated appropriately. According to the World Health Organization, the increasing adoption of risky behaviors such as smoking, the harmful use of alcohol, inadequate intake of fiber, fruit and vegetables, and lack of physical exercise are major contributing factors for increased risk of cancer. Chair and honorable members, you will find that throughout this presentation, we repeat these risks because it's things that South Africans can do without. South Africans don't need to smoke. South Africans don't need to overdo it with alcohol. It's easy to take in fiber. Fiber's amongst the least costly of foods. And then it's easy for all of us to just exercise, even if it's just in the home, in your small dining room, to do passive exercises there. So these risks can be avoided, but for some reason or other we don't, and we have this high burden of disease. We continue with cancer in women in South Africa after indicating that black South Africans, black women, are mostly affected with cervical cancer. The data shows us that white females had the highest incidence of breast cancer, but colored women has the highest mortality rate. It's important that we still talk in race because the legacy of apartheid has left us with different conditions amongst the different races. And access to health is still not the same amongst the different races. So even though more white women are diagnosed with breast cancer, more colored women are dying of breast cancer, and it's also suggested that they seek help late, and they are diagnosed, colored women are diagnosed when they are at a more advanced stage, and these are the things we're trying to change through aggressive health promotion and awareness. Awareness of the symptoms of cancer and early detection and treatment have been shown to be the main intervention in reducing the risk of breast cancer mortality. Cancer in men and in women is a preventable disease that requires major lifestyle changes. Only 5 to 10% of cancers is that kind of cancer that you would get anyway. Whether you try your best, you would get it because it's genetic and it runs in your family. Only 5 to 10. Whereas 90 to 95% of cancers have their roots in the environment and lifestyle factors like cigarette smoking, poor diet, excessive alcohol intake, sun exposure, environmental pollutants, infections like the HPV infection that causes cervical cancer, stress, obesity, and physical inactivity. And if I should have made one of these red, it is obesity. But obesity is caused by eating wrongly, overdoing it with alcohol, and not exercising. The evidence on cancer-related deaths is that 25 to 30% are due to tobacco use, 30 to 35% are linked to diet, 15 to 20% are due to infections such as the HPV infection, and then 15% is radiation from the sun, stress, physical inactivity, and environmental pollutants. Therefore, cancer prevention requires smoking cessation, ingestion of fruits and vegetables, moderate use of alcohol, restriction of calories, which means not overeating, exercise, avoidance of direct exposure to sunlight, minimal meat consumption, use of whole grains, and use of vaccinations and regular checkups, especially breast checkups and pap smears. So, Chair, we are saying that the HPV vaccination is an important tool in our toolbox to prevent particularly cervical cancer. And we thought we'd just share with you the progress that we are making with vaccinating schoolgirls in grade 5, 6, and 7. And it also goes there according to the provinces. And we can see that our coverage are quite high. We should do better in the Western Cape and in the Northern Cape. In fact, the other provinces that's not up to 90%, we should get them up to 90%. But we do have to get consent from parents for these vaccinations. And unfortunately, amongst us, we do have people who don't believe in vaccinations. Very sad. Chairperson, from the cancers, we move to mental health. And the data shows us that over the course of a lifetime of a person, mental disorders affect 30% of South Africans. I'm moving to the next box next to it that says gender differences. And it shows us that women are mostly affected by anxiety and depression, and more men are affected by substance use. I'm moving down to the box that says prevalence of disorders. So you find anxiety disorders amongst 15% of South Africans. Mood disorders like depression, you find it amongst almost 10% of South Africans, and then substance disorders amongst 13% of South Africans. And the key drivers of mental health in South Africa is poverty, violence, HIV and AIDS, and substance use. About mental health, this is what we're working on to relieve this burden, and we share with you the salient features of the National Mental Health Policy Framework and Strategic Plan that was adopted in 2023, and that we will have to review around 2029 so that we have a new one starting in 2031. And so what we are focusing on is to strengthen district and primary healthcare-based mental health services. In this regard, Chair and Honourable Members, we've got a special grant that goes to the 9 provinces, and that grant must be used to employ psychiatrists and psychologists and more social workers, and also to deploy the psychologists and social workers to primary healthcare clinics. We must build institutional capacity, and so it goes with those resources that we hire in point 1, but also to have strong training programs to be able to early detect mental health and to treat mental health properly at primary healthcare level. We conduct surveillance and research and strengthen innovation. At this moment, we rely heavily on our research organizations and the universities because we don't have a good routine data collection system with regard not just to mental health, but with regard to all non-communicable diseases, and we are working on getting better data for these conditions. Number 4 says develop and improve infrastructure and capacity of the facilities. We're constantly doing this through the Ideal Clinic program to upgrade clinics, make better space available, and so on. Monitor availability of mental health technology, equipment, and medicines. Strengthen intersectoral collaboration. Increase and strengthen human resources for mental health. Improve advocacy, mental health promotion, and prevention of mental illness. Just again, to point out the difference of NCDs in general, in women versus men. And this is where this difference comes in with the first one, Chair, that speaks about overweight to obese persons. And this is what I was pointing out when I said more women died of COVID the number of women dying went up with COVID because there was a strong correlation between COVID and obesity. And if you look at how much more of South African women, 68%, are overweight to obese versus men, 31%. 31% is very high already, but 68 is really astronomical. And so with us, this is why we've got the Chief Director for Health Promotion here, together with the Chief Director for Non-Communicable Disease Control. For us, this is our number one thing, and in follow-up slides, we will share with you what we are doing to get South Africans aware of this problem. If you look at obesity alone, which means you now look at a much more higher weight, women, 41% of South African women are obese and 11% of men. And therefore, you look at the diabetes deaths, 8.6% of women die of diabetes, whereas 5.2% of men die. Again, obesity is a risk for diabetes. In fact, it is the forerunner of diabetes. Hypertension, women, there's a lower incidence, there's a higher incidence in hypertension in women than in men. And we see that women are less physically active than men, and it's probably still that the practice in South Africa that the homemaker and the one who has to do things in the home is more women than men. Men are given more free time to engage in maybe physical activity, and through health education and changing the environment, we have to improve those things. And then there's an increasing trend of premature deaths due to NCDs. The trend is that it's higher in women than it is in men in South Africa. Chair, I think I spoke to this slide. I'm not going to, this one's, I have to speak to the slide. I thought it was just about the women again. In the African region, South Africa is the country with the highest proportion of obese adults. We are beaten by Egypt, but Egypt falls within the Eastern Mediterranean region of the World Health Organization. But if you look at the map of Africa, Egypt has a higher rate of obesity than us, but except for Egypt, we have the highest rate of obesity, and we really, really have to address that. Now, based on the data, and because we have limited resources as a health sector chair and honorable members, we have prioritized 5 non-communicable diseases, and they are cardiovascular diseases, diabetes, cancer, chronic respiratory diseases, and mental health. We did the slide in this manner because you had specifically asked us to come and present on NCDs, but when we go out as the national department, and by going out, I mean that we have active programs with the provinces where we have community engagements, large community engagements in tents with the communities. We don't speak about 5 priority conditions, we speak about 7. Because the same women and men who have diabetes may also be HIV positive still. They may also have TB. So our 6th priority condition is the infectious diseases like TB and HIV. And number 7 is the health of mothers and children. So when we go out into the communities, we speak about those 7 priorities. And then, of course, we put that plus obesity, because obesity is the underlying factor for most of these conditions. And then we speak to the communities about the risk factors, which is tobacco use, harmful use of alcohol, physical inactivity, unhealthy diet, and then air pollution. And then because of number 6, the communicable diseases, we speak about safe sex, and We also talk about health of mothers and babies, which means please, as soon as you find out that you are pregnant, come to the antenatal clinic, visit the antenatal clinic regularly. When baby is born, make sure baby has all the vaccinations that the baby need, and that we do growth monitoring to make sure both the mother and the baby's nutritional status is what we desire. This slide just goes more in depth with the modifiable risk factors to say that tobacco use, excessive alcohol intake, unhealthy diet, inactivity, and air pollution causes raised blood pressure, causes raised glucose, overweight, and obesity. And that in turn leads to cerebrovascular disease and stroke, diabetes complications, cancers, and chronic respiratory conditions. So we move to the summary of the health sector's response to the NCD's chair and honorable members. In terms of health promotion, we are implementation of the National Health Promotion Policy and Strategy, emphasizing health education, determinants of health, and collaborative multi-sector action. We have public health campaigns promoting healthier diets, physical activity, and reducing harmful substance use. We have regulatory initiatives, and here we talk about the sugar tax that we brought out a couple of years ago, regulation on trans fat control, and our regulations on reduced salt in key foods used by South Africans like breads and flours. In terms of prevention, again, we have national awareness campaigns in collaboration with the World Health Organization. We have the community-based screenings. When we go out to those mass meetings with the communities, we do screening for blood pressure, blood glucose. We have a trained cadre of community health workers who do this all the time, not just during campaigns. We have also done extensive training in the last 2 years with the traditional healers on the recognition of mental health and referral. We have also trained traditional healers on taking blood pressures and blood glucose, and we are also supplying them with the supplies to be able to do so, because we know there's a large proportion of South Africans who do use traditional healers as their first port of call. We screen and manage NCD risks in women of all ages. There's collaborations with partners from education, sports, and social development to promote healthy lifestyles. We have, I hope that all the members of the steering committee know about South Africa's Park Runs. I'm saying South Africa's Park Runs, but Park Run is a global initiative that takes place every Saturday. In South Africa, all over the country, it starts at 8 o'clock in the morning, except for Uppington. Uppington is the only differentiator. In Uppington, they start 7 o'clock. It is a run in your local park for 5 kilometers. Lots of us, like me, we walk more than what we run. But we have a collaboration with the park run managers in South Africa, and we are actively building together with the local municipalities the parks in our townships to make sure that park runs do not just take place in the affluent areas, but that there are park runs in the townships as well. And we've had great success in Soweto together with Park Run. We've already opened, together with Park Run and with local political leaders, we've opened 2 parks in Soweto. We also in the Western Cape, we worked with the Western Cape government, local municipality, and when I say we, it's us, the National Department of Health and Park Run. And we opened a park run in Stellenbosch that was functioning but previously closed. And so we're doing a lot of this work around the country to make sure South Africans get moving close to where they live in a safe environment and at no cost to them because the park runs are free. Early detection is, of course, about the screening. In terms of management and care, we're doing primary healthcare strengthening through the Ideal Clinic program. We make sure that the facilities have the resources for managing chronic diseases, including mental health. And we have continuous training of our clinicians through formal training programs in partnerships with our universities. Policy and regulation. Policy and program levers include regulation of tobacco use, alcohol harm reduction, food labeling, healthier food environments in schools and workplaces, and then urban design that enables physical activity. And I spoke about what we are doing about Park Run. That is the end, Chair. We can take questions and comments. Thank you.
Thank you very much, Ms. Santa. Can I check any members who would like to, any comments? In the absence, okay. Honorable Nodada, Honorable Tembekwayo, those are the two hands that have popped up. Honorable Nodada.
Thank you, Chairperson. Good morning once more. Chairperson, let me take this opportunity to welcome the presentation by the department. It is so exciting, though also frightening to understand that women are in such danger health-wise in South Africa. I'm also one of those women who are in the high obesity problem. But Chair, what I just wanted to talk about, I have no question, but I just want to talk on two issues. The diabetes is #1 killer in South Africa, and also the deaths that have gone down on TB. I just want to talk about TB first and say it is a great pleasure to say that well done to the Department of Health and say they should proceed to make sure that we do away with TB, because really it is curable. And if they continue with the lessons, just to tell people about the stigma, because some of the people still die of TB because they stigmatize it, and it is just a disease, just like other diseases. Chair, in the issue of diabetes, it's a matter of concern. More people really take it as a normal way of living, yet it is not. I don't know, maybe in our sittings as women, we can also assist the Department of Health now, having heard that diabetes is #1 killer in South Africa, and women are the most affected. The manner in which women of today are drinking alcohol, the manner in which women of today are eating meat, and they are said to be the causal factors for diabetes. I should think we need to teach or to try to make awareness on ourselves as women in our gathering. Otherwise, Chair, I just wanted to thank you, the department, for welcome the presentation made. Thank you so much.
Thank you, Honorable Tembekwayo.
Thank you, Chairperson, and thanks for the presentation for today. The first suggestion is the presentation that was done today needs to be repeated to a broader multi-party caucus. It's very important. because as women, we need all of us to be involved in saving the nations. And that can be done if definitely we are all under one umbrella, and then we discuss the information as it is given to us today. So with specific reference also to this new thing of the Park Run South Africa, which is part of the prevention campaigns to non-communicable diseases, as it mentioned. So it would be better if everybody knows, is aware of it, and then it is also implemented, like they say, in all 9 provinces. But if it's in all 9 provinces, where specifically is done, because it has to be done all over where there are people. And the question that I would like to ask is based on the existence of Itemba labs, the one that is in Western, it's here in Western Cape, around Grabo. We went for an oversight there, even though it's part of the SANSA the department, but it's a leading research facility in South Africa that is making significant strides in cancer treatment, particularly with the radioisotopes for diagnosis and therapy. They are producing vital medical isotopes of South Africa patients annually, with plans to increase its production. So my question would be, what is the relationship of Itemba Lab and the Department of Health? Because what they are producing is very important. If there is a relationship that is existing, I would like to know how many patients are benefiting annually from these isotopes. And if there is no relationship with the Itemba labs, I think it's high time for the department to take note of the existence of Itemba lab, because of the fact that they also reach out to the communities, and also they are involved in the research related aspects. Thank you. Thank you, Chair.
No, thank you very much, honorable members. Mine Ms. Sanda will just be some comments and recommendations for the department to look into. First, because I want to make this comment, because we want to assist and empower communities. I think it is going to be important, in agreeing with what Honorable Thembekwayo have said, of presenting this to the broader multi-party women's caucus, that you categorize, I'm looking off the better word, that we must be aware now that which provinces obesity is just out of control, so that it's not a general comment. Remember that members have got constituents areas. In fact, South Africa is our constituency. Whether if I go to Mpumalanga, I say this, I'll make an example, I'll have to report on that. But it will be important. I'm in the Eastern Cape, I am in Gqeberha. That in all, I know it may be quite a cumbersome work, but I do think that it is important. Even if you pilot by 2 provinces, I'll make an example. 1 rural, whether 2 rural and 1 urban, 1 metro, so that we are able to really develop a program together of empowering our people, educating our people, honest and blunt to our people in terms of if they don't take care of their health, then they are contributing to whatever situation that they will find themselves in. I know there will be then a say that in fact it's because communities are poor, languishing in poverty. That is to be addressed. But if people are, and which are then the other departments that we think can assist in ensuring that those that are poor, when they do have a piece of land, even without a piece of land, I will make an example. Take a tire, an old tire, open it up, fill it with soil, and you plant whatever. So I think this is also challenging us to think outside the box in terms of, as we are empowering our people, as that we are mindful of the economy of our country and the poverty that our people are subjected to, but they've got two hands, they've got eyes. Is it not about time now that in fact we empower our people so that they don't become dependent? I'm raising this thing of province because there is a province that I have observed, and I hope as the Department of Health, you have observed that too, Limpopo. Communities of Limpopo, they work the soil, the land that they are in. Communities of Limpopo, very few, maybe I'm naive or ignorant, that you'll find obese. People of Limpopo, in terms of their physique, you find that they are more healthy. And what makes me to make those observations, Ms. Hunter and members, is that every time I look into, you'll find that they're plowing, they're doing this, they're doing that. Is it only Limpopo? Or in Limpopo, it's a particular region? As health workers, you will know that if you are to cure or to diagnose whatever, there are times that you have to localize, to look into a particular, not to just be to look into the whole. You look into the whole body, but you will then say where in this person there is ABCD. So I hope I'm not creating a confusion, but I think it's going to be important as much as it's race. You have said on some of the non-communicable diseases, but also provinces, so that we are aware which provinces are really taking these things serious. I'm not saying they are not, but which of those that are taking it serious? I have got a concern, which you as people that are more on that, why is it that women are dying of HIV and AIDS more than men, when now we've got only one tablet? Is it because they're defaulting? Or what? If then I can get a clarity on that. My last comment is on a subject that I do think that as members of parliament, working together with yourselves, is mental health. You will have an understanding that there's a very thin line between sanity and insanity. It's a very thin line. I'm raising that because I'm a victim of that. At some point in my life, I nearly lost it because of a number of things. And this thing that people think that mental health is only for people who are poor. Mental health does not have any color, the class or gender, politics or religion. And I'm happy that you say you are empowering traditional healers, but you must also empower them on issues of mental health. Let me just make an example. I have and I'll make an example about myself. When I picked up, we were not aware that my husband now has had dementia, and I was sick because I really couldn't understand. I was a wreck until I went to my GP, and my GP explained, what is this? Because at times when something affects you, you just become blind to some of the things that you may have picked up. Okay? Then you understand. Unfortunately, he then complicates. He also had prostate cancer, which he was attending treatment. But after, and he passed on. And after the funeral, you know, these customs that you must sit at home, you must not go outside. And I find myself that, if I sit in this house alone, when people are gone, you're alone, you feel it. It hits hard. And I had to I told myself that, no, once or twice a week, I must go out just to have. So there are some of the things that we are to empower our communities to understand that if you say a widow must sit in the house, not go out, what are the effects of that mentally? So it's I'm raising that, but the other sub point that I'm having, Ms. Handa and honorable members, is that, and I hope it's now going to be taken very serious. I know for a fact I was a health worker. Mental health, it's there in the periphery at times. The stepchild, they always say it, of the health sector, not only in South Africa, but globally. If you watch some of this of these things, and therefore, I do think that ourselves also, wherever we are, we are to ensure that we improve, we assist our communities to understand, to pick up, and in mental health, not only in adults. When you come back, pediatric psychiatry, or whatever. When a child, when does a mother pick up that this child is bipolar? At which stage? How are they to be empowered? Maybe it's better said than done. But these whole issues that you are raising here, enemy number one to all these beautiful programs, it's human resource. And I think, and funding. And in me stepping down, I want to say, health sector is not producing bags. I always make this example. And when too many bags are produced and they are not being bought, then the company will say, we will lay down 10 workers because we don't have money. I think it's ourselves I think as members of parliament ourselves, we have to shake up the government, in this sense, cabinet, and in this instant, a treasurer. Because we can't be talking about economy to increase the economy when our citizenry are unskilled, are not healthy, and there are no people that are to ensure that at least that happens. So this thing of the grant that is sent to provinces, I hope when you come back, we will then get which of those provinces are utilizing that grant. How do you monitor that grant? Which is, if I got it correctly, it is a grant that is to assist in ensuring that issues of human resource are being addressed. It's so painful because some of us worked in this sector from the last administration, which is before 1994. And we saw how our hospitals were, let alone that they were treated, patients were treated according to the color of their skin. But what was in the hospital, the human resource, the infrastructure, everything, food that they eat, treatment that they get, and therefore I think we owe it to our people. We owe it to our people. Put our political affiliations aside, because before we are activists, we are human beings. We are coming from families. Families, some of them that have got members of our families are affected by this, and who unfortunately are dependent on the public hospitals because they can afford to go to a private hospital. So I think this presentation, in agreeing again with what Honorable Temuka is saying, which is very important, that when you must, we will give you time. I'll communicate with the members of the steering committee. We'll give you time to prepare and come and make that breakdown so that when we do our oversight in our constituents areas, we take into constance that then there are these challenges. My constituents area is Kirkwood. I go to the hospitals. There are there's a mental institution there. What is it that I pick up? Whatever I will be picking up, I will bring it to the department for the department to look into it and address it. And that communication, therefore, is then going to be very, very important. I'm raising those so that when you then respond on some of the issues, but a key, and I'm saying it, I will say it wherever. I will say it even to the highest office of the land. Have all social services in this country. I don't think it is fair. Now we're talking is health and education, but now we're focusing on health. The shortage of staff in our hospitals leaves much to be desired. And all these beautiful programs, in one way or another, it's either they will fail or they will collapse. Our people will then blame the government, whereas there is something in terms of how we plan as the department. Otherwise, it is quite a very good program. I will allow you to respond, and then we will then close the meeting and look into the proposals that we think are to be taken seriously. Not that you are not taken seriously. Some of the things that have been raised. Over to you, Ms. Hunter.
Thank you, Chair, Ms. Dunjwa. I'll start with Honorable Ndlangisa Nodada's comment because there's something I just want to say about that. In early 2000s, extreme drug-resistant TB reared its head. So much so that in 2008-2009, the Health Department, together with the CSIR, the Center for Scientific Research, built special units. I remember I went to the opening when Dr. Zweli Mkhize was still the Premier of KwaZulu-Natal. Special units with special air conditioners to house people with extreme drug-resistant TB in because it was so infectious. And there was no cure for it at that time. The third-line drugs had just come out. So every province had such units. Chair, South Africa eradicated extreme drug-resistant TB. We still have some drug-resistant without the X. But we never even celebrated it. I think we just move from one problem to the next, and it's right. We have to focus on the problem so that we can fix the problems. But I'm just saying there's some things we could be proud of, and that years out, too many people still die of TB, so we are not celebrating. We don't say we are wonderful in preventing people from dying, but the numbers did come down drastically. And I'm not even in charge of the TB program, but I always ask my colleagues and the DG, why did we not even make a fuss when we eradicated extreme drug-resistant TB? It's no more in South Africa, so much so that when COVID-19 came in, I was in the Northwest as a counting officer. We used those special units built to make extra wards for COVID. I just wanted to make that comment, and I appreciate the appreciation from the honourable member. And then to Dr. Tembukwayo, yes, we don't have the stats now, but we will write to the steering committee through the minister and provide the stats from Itemba Labs. There's also the same kind of operation working with the isotopes in the north in Pretoria called Numeri. So we will send you the statistics to the chair through the minister for both those, and also describe to you our relationship with them and how we intend to work into the future to improve their ability to assist South Africans. And yeah, we will inform the minister to expect the invitation to make the presentation to a broader grouping as well. Honourable Chair will remember that when I presented, I said at the moment we rely on data from our universities and research organizations. Because our routine data is not that good. So I don't know to what degree we have per province data, but our Chief Director, Ms. Bongale, who is here, she will go and look at our data, and again, we will provide a report to the chair through the minister. What I do know is that they are about to embark together with the World Health Organization on a survey which we call the STEP survey, and that one will definitely give us the data that the Honourable Chair is asking for, but it is going to take at least another 12 months. Then I will also communicate to Minister, Deputy Minister and DG, but as a program, we're taking it seriously that this multi-party women's caucus is going to help us if we work with you. So I'm asking the Chief Director, who is present here, to send the invitation to the chair for the opening of, I said we already opened 2 park runs in Soweto. We had a soft opening in November of the one in Ribone, am I right? Is it Dobsonville? Reboni. Anyway, in
It is Dobsonville, Dorothy Nyembe, Parkrun.
Thank you. Yeah. Can you, as soon as possible, write an invitation for the minister's signature to the chair that members who are available on 20 February come to the
21st.
opening. Yeah, 21st, eh?
Yes,
Come
21st.
to the official opening that the National Department of Health, Gauteng Department of Health, and Parkrun has of the Dobsonville Parkrun. And then I also just want to say, Chair, if you go to Google and you just put Parkrun near me, it gives you the Parkrun. We, as the National Department of Health, we are in Pretoria, and for us to set an example and put our money and our actions where our mouths are, we've got an active health movers group in the National Department of Health. And we go normally from Parkrun to Parkrun. And if there's any members in Pretoria, we would like for the members to join us just to get that introduction into Parkrun. It's really a good way of starting to move. We all go at our own pace. We meet each other at the beginning and we say goodbye, because some of us are faster, some of us are slower. But it's a very good way of starting to get off the couch and just moving. And also, Ms. Nsie and Ms. Mongali, the community outreaches that we have, the expanded screening campaigns, if we can also put through the minister an invitation to the chair, so any members who are available could join us, and we would give the multi-party caucus members, spots on the agenda to speak, because we need people with profiles to speak to the communities about these issues, early screening, eating right, and moving. So we would really appreciate a relationship with you for us to get South Africans to be more healthy and to stem the tide of this non-communicable diseases that's really on the increase. Thank you, Chair.
No, thank you very much, Ms. Hunter, with the presentation and the comments that have been made by our members. I think the health sector is going to be one of the sectors that, as the committee will be focusing on, of course, it affects young women and old women, and therefore we will then have a dedicated focus, as much as we are also to have a dedicated focus in to men, because a home is a home through a woman and a man. We maybe because of when you come back, we will extend an invitation. When we come back, we will. I was just thinking now. It is not, but think some of the, can I say, addendums or whatever, in terms annexures, in terms of your presentation, the state of school health in our country. I'm raising this because you will know that all of your health workers, you will know that there are young children who are diagnosed with diabetes, hypertension, epilepsy. But again, I'm more concerned about the issue of the mental health. How educators are empowered to be able to. I know it's quite a mammoth task. what I would be told that there is no money, there is no staff. It's something that I just don't want to accept. That as the country, we will, when it comes to issues of health. So when you come back, or in between, we'll see to give you time. Yes, some of the things may take some time, but pilots, even with one province or two regions in a province, in terms of some of the issues that we've raised, obesity, poverty, the issue that I raised about Limpopo. Am I dreaming? Am I naive? Or it's just not there? And how then can other provinces, rural provinces, can what is this thing? Can copy from what some of those, because I don't want us to be very much academic, because we are dealing with communities. Communities, some of them that are not trained in this field, but health is a very emotive subject. How then do we ensure that we simplify for them to understand the importance of some of the things that they are taking for granted? But in the center, I don't know, maybe at a particular time, I don't know whether you have a directorate that is dealing specifically with issues of mental health. Mental health is a challenge, is a problem. In stepping down, closing, we're talking about this thing of dementia, how the thinking of our people, how many of the old women in rural areas were killed by communities because it was said that they are, what is it, Batakata, the witch doctors. Poor souls, because they had dementia. How then do we empower our people to understand? Not only in rural areas, also in urban areas. Even us as public representatives, how we must be empowered to understand, and what is it that we are to do so that we don't find ourselves also being a wreck, as I was, until I was told that if he says this is black, don't say no, this is red. When it's red and he said it's black, said, oh, okay, it's black. If he's saying it's raining outside, say, oh, okay, yes, it's raining. We'll close the windows. Don't argue. And until so many of our people don't know that. So the issue of mental health is very, very important. So when you will then be coming back, we will see, as the steering committee will sit down and see, give you time, and maybe when you set that invitation, we will say what is it that we'll then be expecting of you from this particular subject, with the understanding, therefore, that we'll be told of budget and that there is no money there. How do we do things with the little money that we have? Otherwise, thank you very much. We will, until we meet again, if there is another information that we will need, we will then request the committee secretary to write to the department through the minister. But please relay our concern as the members of the absence of the minister and and then the poor communication that has then created, we don't have energy for perceptions. We have got energy to work. So this thing of poor communication, there's a perception, oh, they don't take us serious or whatever. Whereas there's been a clash, and a clash on a matter that we would have joined that. As the office of the chair, would have delegated some of the members of the steering committee to go and be part of that. So in moving forward, we will then have to do that. But the last thing is that we would like to, I think it will be important that you also, on some of the things, on some of the challenges here, that which department are you collaborating with? The science and technology through CSIR, there's education around the issue of school health, and maybe there were others, but those two have come to the fore. I'm raising that because we must also try and discourage departments to work in silos. We're in a mess because we are working in silos. Committees themselves are working in silos. Having said that, thank you very much, Ms. Sanga. Nice to see you. I last saw you in that other term, 2014, but we are meeting again. There's a young lady who said, morning to everybody, empower the protocols of the committee of Parliament. She will learn. You say, morning, honorable members. Having said that, thank you very much. Our committee stand adjourned until we meet again.
Thank
Bye.
you, Chair.
Thank you, Chair. Bye.